I'd like to thank the organisers for the opportunity to speak on the topic of diet and nutrition in Pompe disease. I speak in my capacity as a consultant in adult metabolic medicine at Salford Royal. I'm also honorary senior lecturer as I'm involved in teaching and research, and also clinical ambassador for a charity known as Medics for Rare Diseases, seeking to raise the awareness of rare diseases amongst medical students and junior doctors. The outline of my talk is going to be, first of all, just an overview of body composition and clinical nutrition, which is relevant, obviously, to understanding the impact of Pompe disease on nutritional status, and also how the disease manifests at different life stages, of which, of course, many of you are intimately aware of. I'll then talk about the direct aspects of nutritional status on Pompe disease and the role of some interventions, both supportive and therapeutic, and as well as discussing possibly issues of specific nutrients, I'll also like to discuss underexplored areas, and that will also touch on the very topical issue of COVID and how to stay well in this situation. The focus of the talk will therefore be initially about nutritional assessment and aspects to nutritional interventions, with the goals of correcting any deficiencies that may be present to optimize and maintain function, and potentially as a therapy to alter the underlying disease course. Those of you who've been to Salford Royal for your Pompe care will almost certainly be familiar with the weighing scales that we have in our outpatient area, but you'll have seen a machine in the corner of the room. To the left, that's a multi-frequency bioelectrical impedance machine, which is a medical grade version of the body composition machines that most gyms have these days. And effectively, this measures the amount of water in the body, and from that you can work out how much is muscle, how much is fat, for example. There are other ways of looking at body composition as well. The low technology approaches include the tape measure, skin fold calipers, and also other anthropometric measures which can measure the thickness of the body and also the thickness of the skin folds on the arms. This area of body composition is called anthropometry, in other words, measuring people. And this, together with some of the more modern and sophisticated methods, can give us quite a useful picture of what the body is made of. And that's obviously important given the muscle changes that happen, especially in Pompe. The technique of bioelectrical impedance is a way of measuring body water based on the simple premise that water, or at least the salty water that's in our bodies, will conduct electricity, and fat, in contrast, is an insulator and will impede the conduction of electricity. Those of you who remember physics from secondary school days may have an idea of the principles of this, full stop. This is the original form in which this impedance was done and doesn't require the person to stand up. It's not quite as precise, doesn't give quite as much information as the stand-on style scales that I showed you in the first picture, but this might be an option for people who aren't able to stand up. Now, this is known as a Dexa machine, which is dual energy X-ray absorptiometry, and this is traditionally a method for measuring bone mineral density. This photograph was actually taken from the hospital I worked at in Melbourne under the directorship of Professor Boyd Strauss, an expert in body composition who ran the bone density service there. But these Dexa machines are widely available, and not only are they useful for measuring bone density, which is clearly important in people who've got risk of bone loss from reduced mobility, but it can also measure through these ultra low dose X-rays not just how much is bone, but also how much is fat and lean mass as well. And depending on the software of the machine, a machine that's set up for measuring bone density can also in principle measure body composition. This is an example of a printout from a Dexa machine, and this is of course from our laboratory in Melbourne, and that came from Professor Strauss's collection. But the interesting thing here is if you do a total body DEXA scan, you can get the body composition in local areas of the body. For example, the left arm, left leg, left trunk, and left total, and the same for the right side of the body, and also arms, legs, trunk, total. This is quite handy and also helps get an idea of what the distribution of body fat is, and this is obviously an important determinant of health as well. This slide summarizes some of the physiological and biochemical stresses that may lead to alterations in body composition and changes in other metabolites. There are differences between starvation and injury, and there are some similarities, but being able to measure body composition may be helpful in getting a better picture on any disease process, and also potentially by response to treatment. Some of the body composition methodologies in Pompe may be of value, bearing in mind that obviously this is in comparison with the general population, and lysosomal storage disorders by definition are disorders of body composition because there's stuff there which shouldn't be there. And so obviously things may measure differently, and some of it may be useful, some of it may not be useful, but it is an excellent start and an opportunity to monitor disease. The next part of my talk is about diet, and the important thing about food and food components is there's far more to food than fat, carbohydrate, protein and fibre. And indeed, this slide of a photograph of a typical Mediterranean diet illustrates many of these aspects. There are many components of food, and while I've touched on those macronutrients, which also need to include water, we have micronutrients, vitamins, including the fat-soluble vitamins such as vitamin A and vitamin D, E and K, and the water-soluble vitamins such as the B group and vitamin C. Beyond nutrients, there has been greater awareness over the last 35 years of what used to be called non-nutrients and better understood as phytochemicals, those compounds found in plants in particular, which provide colour, flavour, aroma. Many of these compounds have enhancing effects on nutrition, but they also can have almost pharmacological-like effects. Or put in a simple way, many of the drugs that we use in medicine today have their origins from plants, such as digitalis from the foxglove, and these would fit in the broad category of phytochemicals. And some plants contain lots of these compounds, others less, but the so-called flavonoids do impart colour, flavour, aroma, and other properties. There are also other components in food. Additives are things which are intentionally added, and they may be natural, they may be synthetic. And then there are contaminants, things that aren't meant to end up in the food supply but do. And I'm sure you're aware of all the issues around pesticide residues, for example, would be considered contaminants, as would be some of the hormones found in meat as a byproduct of agriculture, of farming practices. Talking about dietary protein, the current recommended daily allowance for protein is around 0.8 to 1 gram per kilogram per day, but even these guidelines are under revision because many of the estimates and guesstimates that were made about dietary protein requirements, particularly across the lifespan, were based on quite unsophisticated studies done in small number of subjects about 70 years ago. And as we get newer methods for being able to calculate dietary protein requirements, these may need to be adjusted. When we talk about what protein is for, the traditional comment is that it's required for growth and repair. And amino acids are the building blocks for obviously structural protein, but also enzymes are all forms of protein as well. And you need amino acids derived from dietary protein to make enzymes in the body. And that includes also peptide hormones. So some of the hormones, like the hormones that control reproduction, actually come from protein. So dietary protein also has direct effects on the endocrine system. For example, when you have protein, it does stimulate insulin, and then insulin stimulates growth hormone, which then drives growth and repair. Insulin also can be involved in the brain, regulating appetite, making people feel full, and seems to also have some role in smell, memory, and cognition and thinking. And it might be that it acts through other chemical messengers. And also dietary protein influences the gut hormone secretion, and that affects appetite and blood glucose control. And protein also stimulates the release of glucagon from the alpha cells of the pancreas to release glucose from glycogen. And that's the non-lysosomal route. So dietary protein has many roles. There's been a lot talked about dietary protein in the Pompe community and the GSD community in general. While meat and fish and other forms of animal protein are well known and clearly a very efficient form of getting protein, there are other sources and beyond milk and eggs, and people who are lacto-ovo-vegetarian, for example, the bean and pea family, of which soybean is also a member, is a rich source of protein, as are nuts. And so in prepared foods, there are significant amounts of protein from these as well. And in fact, in Western populations, dairy products and cereal grains do constitute a significant source of protein, particularly wheat, which is actually a high protein grain. Protein tends to be relatively expensive as a source of nutrition, and there are, and beyond protein, in terms of overall dietary quality, is sensitive to social factors. So community groups at nutritional risk, traditionally include the very young, the very old, but also people with chronic health problems, people with disability, and dependent on others to purchase and prepare food, especially if there are swallowing issues. And clearly, combinations of these categories constitute increased risk in particular. In those with Pompe disease, there are some specific areas of difficulty. Clearly, if there are swallowing difficulties, that may limit the food choices. If there are respiratory difficulties, I don't need to say it's harder to eat when you're struggling to breathe. And you do get not only skeletal muscle dysfunction, but you get dysfunction of smooth muscle in the gut as well. And that clearly affects digestion. Beyond the intake of food, inflammatory states affect the way that protein and energy stores are metabolized and utilized. And if there's activation of inflammatory pathways, there tends to be a breakdown of muscle. Weakness and disability can be part of the experience of Pompe. And also, if people aren't active, then you eat less food, and because you rely on eating enough food to get enough of the vitamins and minerals, and for example, there is a risk of micronutrient deficiencies. Vitamin D is, as a case in point, and in many ways, sometimes calling it a vitamin is controversial, because although some comes from food, and especially fortified foods, we're really meant to get most of our vitamin D from sunlight. If you've got an indoor lifestyle, or you've been in lockdown and self-isolating and not going out, you will not be getting enough vitamin D potentially from the sun, and so it's really important to take a supplement. The other thing is that if you're not able to be as active, there's a loss of muscle relatively, and an increase in body fat, as well as the risk of bone loss. Let's look at this in a bit more detail with respect to Pompe disease. So as the disease progresses, increased body weight in proportion to muscle can compound disability. So there's more weight but less muscle function, and bulk to be able to carry that weight around limits what you can do. It's really important to ensure at the first that you have enough protein, because if you don't do as much and you don't eat as much, then protein intake can also be compromised, and that may exacerbate muscle loss. And if you don't have enough protein, then you can break down your muscle and use it for energy. But also, if you have too much protein, the body will actually use that as an energy source. So it's good to have enough, but not necessarily too much. And the other thing is, if you have excess amounts of protein, the body will actually turn it into glycogen if it's for a significant proportion of it, that is. Carbohydrate is a source of glycogen, and carbohydrate restricted diets have been explored as a way of reducing the substrate for the alpha-glucosidase enzyme. The issue is that actually, if you have carbohydrate and you're using it and you're burning it up for energy, then it tends not to get stored as glycogen. Also, if the sort of carbohydrate you have is absorbed slowly, you've got a better chance of burning up that carbohydrate for energy. Whereas if you have, say, a can of Lucozade, or a very high, what we call high glycemic index, of a lot of carbohydrate which is absorbed quite quickly and used quite quickly, then that will go to glycogen. And whilst with Pompe disease that will be available for energy, there is the risk that more of that will end up in the lysosome. So it has been around in the literature for some time, and reviewed, a nice review by Tarnopolsky 18 months ago. And this includes ketogenic diets, which I know we do get asked about, and they have been explored anecdotally in Pompe patients. There is some mouse data experimentally. Ketogenic diets, which is where you have an ultra low carbohydrate diet, and most of the energy comes from fat and modest amount from protein. This can certainly stop glycogen being produced, but it is a diet which really does need very close medical and in particular dietetic supervision, and it may be possible to achieve benefit without going to such an extreme, and perhaps have a diet that has more variety. Vitamin D deficiency or insufficiency is a case in point about micronutrient status in Pompe disease. Even in the general population, muscle weakness can occur when the vitamin D is under 40 nanomoles per litre. That can still be regarded as minimal vitamin D deficiency in the reports coming back from the GP. But that is relevant for Pompe, and it's really important to make sure the vitamin D is at least above 40 to 50 nanomoles per litre. Vitamin D deficiency also results in reduced calcium absorption. And while at the extreme, most severe level, diseases such as rickets and osteomalacia, where you get very soft, bendy bones, and with it severe bone pain, as well as muscle pains, actually you can modify calcium absorption with vitamin D levels of up to 75 nanomoles per litre. So if you want to have the best vitamin D for healthy bones, you really should be aiming at a level over 75 nanomoles per litre. When you get vitamin D levels over 100, it starts to influence immune function. And if it goes substantially above this, then we're unclear as to how this impacts on Pompe disease if it goes really high. We do know that at high levels it can have a favourable effect on autoimmune diseases, but that is again an area of controversial research. So my simple recommendation is it's important to avoid deficiency and insufficiency, and I would aim for a vitamin D of 80 to 100, maybe 110. Make sure that you get all the immune benefits and optimal muscle function. When it comes to other micronutrients with respect to the Pompe population, we have surveyed our IMD population at Salford, and I've had medical students come in and audit the nutrition data that we routinely collect in clinic, and we have found significant percentages of key nutrient deficiencies in our population as a whole. Much of this will reflect the north of England, but where there are problems in terms of swallowing, eating, purchasing, all those risk factors for nutritional status may be reflected. And, for example, vitamin C deficiency is not as uncommon as previously thought, and we do not infrequently come across cases of scurvy in our patient population, and I'm sure there's a lot more out in the wider population. We measure folic acid a lot, and folate deficiency is not at all uncommon. It's quite common. Zinc deficiency is also common, and you need zinc to utilize protein. Again, this is not so much an issue about Pompe disease, but it's about staying healthy in general. When we talk about interventions in Pompe disease, we're clearly wanting to make sure that we correct any deficiencies to avoid worsening functional deficits. We also want to make sure that people are getting enough calories and with that nutrients to maintain health, and that may require nutrition support in certain circumstances, for example, taking supplemental drinks or by tube feeding if needed. It's important to remember that before the institution of enzyme replacement therapy for Pompe disease, we were left with supportive and other therapies. About 20 years ago, I had the privilege of listening to a lecture by Al Slonim from New York on the dietary management of glycogen storage disease. But he also looked at dietary manipulation specifically for Pompe disease and published this in 2007. Interestingly, he looked at a diet that contained 21% protein, 43% fat, and 36% carbohydrate. This contrasts with your average Western diet traditionally being around about 13% protein and about 40% as fat, with the remainder being carbohydrate. So what he was trialing was a higher protein and lower carbohydrate, but not low carbohydrate diet, and the total amount of fat was about the same. Interestingly, if we look at traditional diets with this proportion of nutrients, it's quite similar to the traditional Mediterranean diet. Now, when people think about Mediterranean diets, people imagine it's just drinking red wine and having lots of pasta. But that's not what Mediterranean means in the scientific literature with respect to diet. The data actually originally came from Crete in the 1950s when researchers were looking at the relationship between dietary fat and heart disease. And in most countries, the more fat, the more heart disease. But one country that stood out as being a complete outlier was actually Greece, specifically the island of Crete, where people had a high fat intake, around 40% of calories of fat, but very low rates of heart disease. But actually, when you drill down, they had a very healthy diet with lots of fruit, vegetables, nuts and whole grains and fish and low-fat dairy products, and very little in the way of refined sugars and very little in the way of red meat. And this diet had around 20% protein, 40% fat and 40% carbohydrate, which intriguingly is quite similar to what Slonim was trialing. Before I show you the slide looking at the effects on Pompe specifically, it's important to note that this traditional Mediterranean diet has been reported to be protective against heart disease and also cancers, and is anti-inflammatory. So beyond the macronutrients, the different components of food may also have a positive impact on health. However, Slonim didn't trial a Mediterranean diet. He just did a modified American diet, modifying the micronutrient, in particular the macronutrient composition. I'm going to go to the next slide to show this. So this slide shows the muscle biopsies of two brothers with enzymatically confirmed Pompe disease. They had an initial muscle biopsy at age 20 months, which was part of the diagnosis, and subsequently they then had early institution of nutrition and exercise therapy. So they had the diet, which was lower in carbohydrate, higher in protein, and also regular physical exercise, so that really it ought to result in less glycogen being deposited. This paper was published in Muscle and Nerve back in 2007 and shows the two muscle biopsies 14 years apart. And you can see in infancy there's lots of glycogen in the muscle cells, but by adolescence this had markedly diminished. Obviously this was a small study, and shortly afterwards enzyme replacement became widely available, and so the significance of these findings may have been lost. But it's important to be aware of what other options we have, because arguably we could get a better effect from this sort of approach combined with enzyme replacement therapy. And certainly if people have had to pause because of supply issues or COVID issues, that it gives us something that we can control. Clearly more research is needed. There have been other studies looking at whether or not exercise during enzyme replacement therapy improves delivery to muscle, and it is an area of ongoing research, but that's where we're at. And I will go on to the next slide. So glycogen breakdown either needs glycogenolysis, so exactly burning up glycogen as an energy source, or it needs functioning autophagy, which happens at a subcellular level to recycle cellular products. What drives autophagy is influenced by energy balance, and that comes down to diet and exercise as well, as to whether the cell is making lots of stuff that it doesn't need, or whether the cell's recycling systems are activated and therefore making use of compounds and breaking them down more effectively. This is illustrated in a diagram from Nina Rabin's paper in 2012 in the American Journal of Medical Genetics, and illustrates the pathways of glycogen either being as an energy source or then being scooped up and ending up in the lysosome, where it then needs to be broken down. And that, of course, is the process which is more challenging in Pompe disease. If, of course, this autophagy process is disrupted, then there can be a whole lot of other effects on cell function. And this doesn't just stop at the lysosome, but actually it can then result in problems at the mitochondria level and other organelles in the cell. So having optimal autophagy is important, and it's a key issue in lysosomal disorders. Autophagy is about the regulation of compounds in relation to energy and nutrient supply in cells. And if this doesn't work, if it's unbalanced and you're either it's not happening, or you are got too much or too little in the way of nutrition, then that can impact on cell function in a negative way. So it's about the balancing of autophagy, and that is significantly influenced by diet and by exercise. This review from Tana Polsky summarizes this in a diagram showing that nutritional therapy using a mixture of exercise training and optimal nutrition has the potential to ensure that this autophagy process is as balanced as possible. Because if it's not balanced, then you can end up with failing to recycle key parts within the cell, or having mitochondria that don't work and resulting in cell damage, which will then make the muscles deteriorate more quickly. And then that boils down to cardiorespiratory, breathing muscles, skeletal muscles, and then the issues of impaired mobility, fatigue, and the need for ventilator assistance, as we know. So that brings us to the topic of course, the potential influence of Pompe disease on COVID-19 risk. Now, this is obviously a very topical area, and there have been lots of questions which have been directed to individual clinics and clinicians, and I'm not there to comment on any individual's circumstances. But from a biological level, this is a virus where clearly if you've got respiratory muscle weakness and gut dysfunction, activation of inflammatory pathways, that may confer vulnerability. The other thing, and this is something that we can do something about, is of course vitamin D. I've talked about before, but there's a very nice review, and I've got the hyperlink to it, looking at the possible relationship between vitamin D deficiency and COVID. It is an area that's perceived to be controversial, but if we take the standpoint that having vitamin D deficiency is not a good thing anyway, it does make sense to ensure that it's adequate by supplementation as required. And I would certainly recommend over the winter months that people ensure they have adequate vitamin D. It's policy for many vulnerable groups to do this, and there may be benefits specifically for Pompe, even if you do successfully stay away. And then obviously, because Pompe can limit physical activity, there is the risk of increased body fat, including fat around the middle, as well as more fat in muscle. So those factors are also conferring some risk, which is why I guess many people have been advised to shield. But it's important to also know that we have the opportunity to modify some of this risk, and hopefully the vaccine will also roll out soon. So the other thing is not just vitamin D, but many other nutrients are really important for balancing immune function. And while the vaccines now coming available, and antiviral strategies have been used in selected circumstances, and there are ways of dampening down inflammation, for example with dexamethasone, steroids. There are things that we can also do from a nutritional point of view, certainly making sure you have adequate protein, because this is a virus which does seem to influence protein metabolism, but also just making sure you have enough vitamins and minerals to make sure that the immune system is working as well. And having it in the form of good food means you also get lots of natural antioxidants. And again, there's enough data that this is good in general. If it helps in the specifics, that's a bonus. This slide shows how virus entry into the cell can trigger a number of cell signaling and inflammatory pathways, which have the potential to be modified by pharmacological agents, by medications, and by nutrition. And while the science is still emerging, there's plenty of evidence that having a good diet with variety, lots of fruit and vegetables, and also omega-3 fatty acids from fish are also inflammatory. Many of the compounds found in fruit and vegetables have natural anti-inflammatory properties, which means they won't work as a drug, but over a lifetime of healthy eating, they can potentially modify the risks of chronic disease. There is literature on that. Scientists will always continue to argue, but and we also understand that, you know, if people do have the chewing and swallowing problems, as Pompe disease advances, having a meal like this will be difficult. But if you've got the opportunity to have access, you know, to a blender, so as well as any supplements that might be needed, there may be benefit to at least including some blended whole foods as well, and ensure that what goes in gives you the best chance. And I'm happy to follow up with questions if you want to present them online or through the organisers or through Salford. As you understand, we're all fairly busy at the moment given the pandemic, but we're here to support the community, the rare diseases community as a whole, and that includes our patient groups with Pompe disease and their families. So thank you. And I hope you stay well throughout 2021, and our centres are here to support you. All the very best. Thank you.